So we're really lucky today that we have panelists, and what we're going to start with is with the Executive Office on Aging, and Nancy's going to be talking about the broad context of what's coming down nationally and the local application in Hawaii for older adults. And then we're going to have Ken Zeri speak about end-of-life care and palliative care and the continuum of care, transitions of care, and that'll lead to Duane talking about what you folks are doing in the home-based setting. So with that, I'd like to introduce Nancy to come up.
Thank you. Oh, I guess I have to hit one more button. Yeah. With the apologies of Wes Lum, our director of the Executive Office on Aging, he really does wish he could be here, and he was called away at the last minute, so I get the fun job of being with you all. I wish I was here with you all day, but I haven't been, so I'm going to catch up with a lot of good information from people I've already talked to. And so we would like to introduce building and coordinating care with the Aging and Disability Resource Centers. As we know, and you probably have touched upon today, we have a growing number of older adults nationally and certainly in Hawaii. We have more than 500,000 folks, kupuna, over age 60, and family caregivers, unpaid caregivers who take care of them. We have at least 170,000 of those folks here today, and that number will be growing as time goes by. So that's quite a large percentage. About 30% of our statewide population falls into one or the other of those categories. So growing number of older adults and the needs that go with the longer life and higher numbers of older adults is very much a part of what's driving change. But at the same time, we are familiar with the Aging Services Network that the Executive Office on Aging is part of has been really in development since 1965. The Older Americans Act was adopted, and our systems that we have now began to be put in place and have evolved somewhat over that time. In current times, things are really changing fast with sequestering and general funding cuts. We know over the past years since 1980, the amount of money that we spend for social-related services that help older adults remain at home through the Older Americans Act have gone from about $9 and something cents a person to two-thirds of that in the present day, even though while the numbers of folks have been growing and the funds have been reduced. Along with funding changes comes all of the exciting opportunities that are part of the Affordable Care Act. And there are plenty of them that we'll be able to take advantage of in our state here and in our different communities. We have big change on the horizon that's come about in the last decade or so when we really have watched the disability community that's younger than 60, including folks with disabilities who are older 60, come into a sense of power to drive to drive services and supports towards to meet their own needs. And the Aging Network that we work with, we're the folks who help to create long-term supports and services in the home and community-based setting so that folks can remain living in their home for as long as possible and avoid having to go into facilities as long as possible, so that for the most part, we know that folks do like to remain in their usual communities and homes for as long as possible. So we have watched our services grow, and sometimes we tend to think of older adults, those folks over 60, and think, oh, those poor folks, we will do for them. We will take care of them. We are the ones who will kind of maternalistically or paternalistically create things that will help them. So that's kind of been part of our history from earlier times, and that's been changing. And one of the ways that's been changing is we watch the independent living movements and the disability rights advocates really blaze a trail that we should learn from and are learning from. On the national level, the United States Department of Health and Human Services took the sections, the administrations that dealt with aging and the offices that dealt with disability, and recently put those together into a new entity that combines those, called the Administration for Community Living. So that's a national model that we're learning a lot from here in the state of Hawaii, and we're really allying our work to be, as the aging advocates, to be much more in concert with the folks who are advocates for younger folks who also are experiencing disabilities, like many of us are. Therefore, with all of these kinds of changes, as above you can see here, we have old models of the way we've always done things, that kind of, we will get grants, we will provide services, we will mash it all up into a big pile and figure out who needs what on an aggregate basis. That's the old model. Now we need to look at new models, because those service provision models are out of date, and maybe you've heard about this today. The visions that we have for a systems change, the system that provides for these home and community-based services to older adults of any age, involves taking a good look at care transitions. We want to become, and are on a pathway to become, much more involved with learning the best practices and the evidence-based ways to help folks go from acute care to home, or from skilled care to home, or from long-term care facility to home, or adult residential care home to their basic family home. And those are real important points of transition where we're learning to have a lot to offer. Aging and Disability Resource Centers are that. There's a national model for Aging and Disability Resource Centers to become serving every community as highly visible and trusted sources where people of all ages and all incomes can get information on the full range of long-term support options, because we all will need to look at those no matter what our income or level of ability. And on the full end, the ADRCs, the Aging and Disability Resource Centers, become the single point of entry for access to public long-term supports and program benefits. Along with that, we mentioned consumer direction, where it's really the consumer, the participant. We call this person by so many names. We call them sometimes the patient, we call them the client, the consumer, the participant, the resident. No matter when we're moving settings, sometimes we call them different things, but they're the same person, and they're really the person who is in charge of what is to happen. They need to, their health is increased when they can use the power that they have to direct their services and supports to fit with their cultural, their needs, their preferences, their values, their individual lifestyles. So we're also working hard to develop consumer-directed ways of delivering home and community-based services. Those are the large changes we're working on. So some of the opportunities that come with these changes are new lines of business for us. We can have the expertise that we have already and are building in long-term supports and services, because it adds value to all kinds of different arenas, the managed care organizations, insurers for Medicaid. We have programs that use evidence-based models to do care transitions, as we just talked about. Evidence-based healthy aging prevention programs are installed throughout our counties, through our county offices on aging, through initiatives that were started at the federal level, but that we've carried out into our local communities, so that folks can maintain their health with evidence-based interventions. We're honing our ability to do assessments that help the consumer figure out what their personal needs might be and how to incorporate the full range of what might help them to stay at home while discovering their personal preferences, values, and interests. And so we're becoming more and more imbued with the ability to do comprehensive in-home assessments using the InterRide tools, which really bring in a lot more domains of taking a look at a person than we had historically done. and of course other creative functions. We're in development through a national model as well to work along with the Veterans Administration to take that consumer-directed model, the participant-directed model, and bring it right to veterans of all ages, not limited to those over 60, and to be able to provide a path for those veterans to direct the care that they need to remain living healthily, quality of life at home, despite injuries and disabilities they may have. At the same time we're doing all this, we're not throwing everything out with the bathwater. We're going to keep our safety net programs and keep charging ahead to find new and efficacious ways to deliver safety net programs like basic transportation support, nutrition, and social support so that folks can avoid being isolated in their homes if they're experiencing declines in function. One of the nice features about this all is that we have the ability to use much more data. We have taken advantage of the drive towards technology. At the same time, we're bringing our touch skills in place as well. And so we're delving into ways to gather a lot more information and use it creatively to not just count how many outputs we can produce or how many trips to the doctor we can drive people to. Come of all that. How and in what ways does it contribute to the quality of life for older adults? And in this way, we can use the quality indicators and the data that we collect and the experiences of all of the consumers that we are working with to show what the health outcomes are, that those could be positive as we work with evidence-based in mind. And ultimately, we'll probably, and we feel firm, and we'll take a look to show that it brings about cost savings in how we deliver care to folks as well. So those are the broad brush strokes of the kinds of changes that we're seeing happening right now, and I thank you very much.
While Ken is setting up his slides, I just wanted to do a little more brief introduction that we're lucky that we have him as one of our speakers. You know, he is the head of Hospice Hawai'i here, has led the foundation of Kokua Mau, which is our state hospice and palliative care organization, but also serves on the board of the National Hospice and Palliative Care Organization. So when he talks about shaping policy in hospice and palliative care while he's shivering from the cold that he hasn't recovered from since morning, he's bringing both the national and the local perspective and the implementation here.
Thanks, you, Rachel. And good afternoon, welcome everybody to our full-day study on hypothermia. I'm sure that we have an IRB on file somewhere. So I want to talk about the macro trends of hospice and palliative care and what we're seeing both in this state and nationally. We've had a lot of conversations today about technology, about using those electronic medical record systems as a way of kind of shaping healthcare. But I'm absolutely convinced that transforming care also involves looking at the systems that we're delivering and how we deliver the care, policies that govern how that care is paid for, as well as understanding the gap where some of those policies may create problems. And I think in particular, and why I'm here, is it includes post-acute care. And the experiences that I'm going to share from our, on behalf of the home care and hospice colleagues really is about patient and family-centered care. When my home care and hospice colleagues and I are attending these classes today, and we hear people say it's about being where the patient and family are, we're like, oh yeah, gee, that's what we do every single day. So while we can bring that instance to this group, we also have a tremendous amount to learn from setting up much more sophisticated systems. So as we begin, I want to start with the definition of palliative and hospice care. I'll read no, I won't read this. I violated the first rule of a slide, which is I have too many words on it. So I'm much better with pictures. When we look at palliative and hospice care, we look at it in a context of some overlapping or some definitions about the care that are consistent between both. So for instance, both a palliative care team and a hospice team has an interdisciplinary team. We are providing pain and symptom management to that patient, and our focus is on the whole person, on their mind, on their body, and on their spirit. And you all know this to be true as well. It isn't just that a patient goes through this process at end-of-life care or suffering a severe illness. It affects the whole family. So a comprehensive palliative care and a hospice care team that's actually providing support to that patient and their family. And when we do it right and we're thoughtful, then it's based upon those patients and family values. Now, there's some differentiation. Palliative care began first in the rest of the world, and then hospice care developed, except we're Americans. So Americans developed hospice care first, and then palliative care has grown out of that in our country. But palliative care is truly these concepts of supportive care for any age, at any stage of any disease. There's no limit to who can get palliative care. For those of you that are freezing and you say, I want to put on a sweater, that's a little bit of palliation from your hypothermia. Hospice care, however, is limited to a patient who's got a terminal illness with a prognosis of about 6 months or less if that disease runs its expected course. And hospice is as much a reimbursement mechanism under Medicare and adopted by most other insurances as it is a philosophy of care as well. So I'll do a quick snapshot of palliative care on a national basis. And actually what we see is a continuing growth and emergence of developing systems capacity for palliative care across the nation. Certainly what we see examples of both of these types of palliative care systems in our state, with inpatient consulting services is the predominant model here, although you can find dedicated palliative care units on some of the mainland systems as well. And we see outpatient clinics and nursing facility palliative care consultations being developed and provided over in this state as well. Now, the current reimbursement stream for palliative care is predominantly physician and nurse practitioner driven. The other members of the team, social workers, chaplains, those team members do not have a reimbursement mechanism. So when we set up these palliative care programs, we're doing it based on being able to bill for at least those other skilled services. And then when hospitals are setting it up, they're looking at saying, okay, well, how is this also helping us avoid costs? And cost avoidance is one of those calculation methodologies that we see coming out of the Center for Advancement of Palliative Care. One of the fun things is seeing the increasing understanding of the science of palliation and the art of that. And as we see this grow and grow and grow, what we also keep having to have conversations with our colleagues is what really is palliative care. I think that the capacity for providing what is palliation is growing faster than the understanding of the implications of defining something as palliative. Certainly it has a significant impact on the hospice community, and that's one of the things that we are wrestling with in hospice care in general. A very quick snapshot for hospice care. There are about 5,000, close to 5,300 hospice providers nationwide, serving about 1.6 million people that get hospice care. No more are we budget dust. There was an age in which hospice in America was budget dust below that $10 billion mark. We're still less than 1% or so of Medicare expenditures, but we're at $13 billion. And the crime of hospice in America is that a third of the patients that have hospice care die in 7 days. This is a program that's designed for 6 months or less, yet a third of them die within 7 days. The median length of stay for hospice is 19.1 days, and only 11.4% of patients in the 2011 data had care greater than 180 days. Yet the most significant concern that MedPAC and Congress and Medicare is looking at is these long length of stay patients. A very quick snapshot here. We have 9 hospice providers serving most of the islands, and a hospice program is in the development processes for serving the island of Lanai as well. This is 2011 CMS data for for the state. We are a little bit behind on the data. We have the 2012 data, but what we do know now is that about 42% of all Oahu beneficiaries, Medicare beneficiaries who die, have died under hospice care, so we're finally right about the national average. We've seen a tremendous growth in the capacity of hospice care for Oahu, and we see the neighbor islands catching up very nicely. We see a lower utilization of home health deaths here. We see hospital deaths are below average. SNF deaths are reported below average. But what's a little bit higher than average, according to the data, is that about 44% have other places of death or other care delivery systems at death. We think that's just an error in how that data is gathered. They may be Medicare Advantage patients, or may indeed been that chronic debilitated patient that developed a sudden pneumonia and passed away. So hospice, under the Medicare hospice benefit, still represents a terrible choice. You can, it's a Part A benefit, and you can choose to either have hospice care or life-prolonging or curative therapies, but you can't get both. That's how Medicare hospice is set up, and it's a terrible choice. Hospice right now is a changing landscape. Actually, the language that we use at the National Public Policy Committees, and I sit on that Public Policy Committee, is that this is a perfect storm in the hospice industry in America right now. There's a whole lot going on. So we have an ever-increasing scrutiny on the eligibility determination for hospice as we see Medicare, just like the RAC and the MIC and the MAC auditors are coming after the hospitals, they're coming after the hospice providers as well in the nation, which then causes increasing regulatory burdens for us. Yay, everybody gets sequestration, at least kind of that's hit us all level, right? And what we are seeing is, just like in the rest of the industry, it's all budget neutral. So while we may see a rate adjustment upwards on Oahu, we see a significant downturn in the rate adjustments on the neighbor islands. So what we end up with is a widening gap between CMS saying don't rehospitalize them and CMS currently saying we're going to make sure that you really know how to do these eligibility, forcing these eligibilities out. We say that the failed chronically debilitated patients have a higher potential to fall between that gap. It's about 10% of all patients that are in that kind of third tier class of patients, costing about 64% of the total expenditures in health care. So as a system, and here's what we have to think, we have to close this gap. We've got to create a safety net to capture and to support those people, recognizing that social support is as important for the frail elderly as medical support is. We have to look at seriously about the eligibility for hospice care. The long-stay patients cost Medicare extra money. They're very concerned about that. But the short-stay patients, I think, cost Medicare more money. We don't see any studies being done on this yet. But those short-stay patients are coming to us after a crisis, after a stay in the hospital, and we're getting them home. And we're not doing hospice care, we're doing brink-of-death care. And it's not how it was designed. So I have the privilege of sitting on another subcommittee called kind of a New Models Committee, and we're not quite ready to give a report, but this is kind of the general impression that I'm picking up from what I'm seeing happening across the nation, and some of it's happening here. We see chronic disease management with in-home support as needed to avoid that emergency room. We see people doing that already here. Hospice expansion into palliative care consulting, that's happening in this island, in this state as well. Consideration of expanding hospice eligibility to 12 months instead of 6 months, and transition type programs being offered to provide that social support. And we see that happening in this state. And one of the things that's really important to remember about the state of Hawaii is this is perhaps one of the most innovative states in what we're doing in end-of-life care. You know, the comment at the plenary sessions was we don't blow our horn enough, and we don't really blow our horn enough. That what we're doing here is got some national attention very quietly. First is the UHA went to full concurrent care program. UHA said you don't need a 6-month program getting care paid for by the regular UHA benefits. HMSA, I got to give my hats off to HMSA. Thank you very much, Ray. Ray is here in the room with HMSA. HMSA 3 years ago said, we want to start doing pay for quality in our hospital systems, and we got all these things that we want to look at, but we also want to look at end-of-life care. They didn't know what that metric might be, and they came to this community, and about a half a dozen of us or so met at 7 a.m. for many weeks and said, what does this look like? And now we see hospitals being paid to set up systems where they're engaging in values-based conversations about choices at the end of life. Not saying this is how you got to choose, but rather saying have a conversation, make a choice. So I think that's done a tremendous amount to support the growth of hospice delivery in this state. And last, as was mentioned at the last session, we are in a pilot program to look at what does a supportive care type of program look like for that patient that might have a potentially life-threatening, a chronic debilitating disease. What does it look like to have that wraparound supportive services of hospice care at the same time as they're getting their disease-altering treatments or their life-prolonging therapies? This is not being done anyplace else in the nation. And this is what's incredible about this state, is the innovation and the partnership that's occurring in Hawaii. So we got a long way to go. We've certainly developed a palliative care capacity. We've got a strong and robust hospice care capacity for serving. Now it's changing the way that we talk about end of life in our state. Thank you.
Thanks, Ken. And as Duane brings up her slides, she's going to share some of the incredible work that Ho'okele Health has done on the Big Island. But I also want to share that, when I go up to mainland conferences and meetings with my counterparts in other states, often Ho'okele Health is there sharing what they're doing. And so they're really, they're able to highlight, as we talk about the lack of tooting our own horn, they're able to highlight the culturally appropriate and home-based care for the patient and family that they're providing here to a larger audience. And so now to you.
Great. Thank you, Rachel. And good afternoon. Thank you for hanging in there in the late afternoon. I was asked to speak today about our Big Island Beacon project, but I'm going to deviate a little bit because I was so inspired by our lunchtime speaker that I wanted to share with you a little bit about what we've learned about the essence of care coordination and what really makes it work. That picture he put up with the physician sitting at the bedside of the child, and it really struck home that what we're talking about here is indeed going back to basics, leveraging all of the technology and evidence base that we know today, but bringing some of the softer side back into the equation and really thinking about walking in the shoes of our patients. One of the experiences that inspired me to start this company, Ho'okele, which means navigator in Hawaiian, was I was, at the time, newly diagnosed type 2 diabetic. And I was talking with my primary care physician and having difficulty figuring out what was the right formula to make all my numbers work. And concluded the visit, he said, well, you know what to do, just do it. And I left the meeting, the visit, going, I don't know what to do. I've tried everything, I'm taking the medication, I don't know what to do. And even though I'm a college graduate, have a master's degree, I've been in the business for 20 years, I didn't know what to do. And that's been our finding as we've done complex care coordination now for nearly 7 years, that one of the most important ingredients for success is making sure we walk in the patient's shoes and we meet the patient where they are. And every patient has a different baseline, where they're starting from. Their health literacy level is different. And it really doesn't matter. It doesn't matter whether you are a college professor or not even a high school graduate. Different people will have different levels of health literacy and ability to manage their own health. So first rule of thumb in our key success factors for care coordination is really to meet the client where they are. We don't call the people that we serve patients. Patients is rather a passive terminology. We call them clients. And if you think about the professional services world, clients are people that hire professionals to help them. And we want our individuals to feel that way. They are empowered to hire us, even though they're not paying for it necessarily, to hire us to help them navigate the system. So first and foremost, meet them where they are at. The second most important ingredient has been partnership with the primary care physician. Primary care physician, the PCP is such an important leader of the team to guide and offer counsel to the patient, and to try to create a system that goes around that or doesn't partner. It just doesn't work. Our clients disengage when that's the case. So keeping that primary care physician firmly as part of the team. And then the third piece is the home. Meeting the client in the home, meeting their family, truly understanding what is their personal situation and what's driving the equation. So let me start with two patient stories that really kind of encompass these three concepts before I go into the actual study report. And then I'm going to go really fast through the report, but a lot of it is pretty self-explanatory. So one of our first clients in this study was uncontrolled hypertensive. And he'd had very, very high blood pressure for several years, in the neighborhood of 200 over 100, always, no matter what. Even the primary care physician was just at a loss, throwing her hands up, going, I don't know what to do next. They were together looking for clinical trials on the mainland to see what might be his solution. We had our nurse care coordinators combined with some technology, which I'll talk a little bit about, help him take his blood pressure readings, log what he was doing, and that really helped him to see cause and effect. What ended up being the issue, he was, out of frustration, mixing and matching his medications, unbeknownst to his physician. Oh, well, this didn't work. Let me take 2. Oh, that doesn't work. I'll take half of that and 2 of that. And he really was trying different combinations every day just to see what would work. She did not know. None of his physicians knew that he was doing this. The second is he had a very, very high salt diet and didn't know it. Even though he had been through nutritional counseling, he had read all the books, he just didn't understand that when he ate plate lunch every day, that his salt content was. And it was really going into the home, talking with his wife, seeing what's in the trash can when she goes for a visit, which ended up in the conversation of him finally making that connection. At the end of the study, within less than 6 months, his blood pressure was consistently down to 130/60. Didn't have to go for the clinical trial. He did not, through the entire duration of the study, go to the emergency room or the hospital, versus previously he'd had several of those in a 12-month period. The second example we had was a woman that was COPD, congestive heart failure, diabetes, on oxygen, frequently going to the emergency room and the hospital. I mean, literally weekly, if not more than once a week, going to the hospital. And until we actually went into the home, again, talking with the family, what was actually happening, unbeknownst even to the client, was they had a generator for their home. They lived in a rural part of the island. And to save money, he would turn off the generator at night. So what happened to her oxygen? That's why repeatedly she would be going to the emergency room first thing in the morning. She'd be fine during the day while she's wearing her oxygen, but at night, he'd turn off the generator. She wouldn't get sufficient oxygen supply. In the morning, she's out of breath, not feeling well, into the emergency room. I mean, literally, it was educating him that he needed to leave the generator on that helped her. She ended up not going to the emergency room again for the duration of the study. So these are the kinds of things, it's really about understanding and really walking in the patient's shoes. So I know this is not alien to all of you here, that this is the kind of TLC that helps our patients improve. But we always get asked the question, well, you're spending all this time and it's very costly and it takes a lot of time from very qualified professionals. Is there any return on investment? Is the cost benefit there? So now I'm going to go through and show you the study, because for the first time we were able, with a very large population, be able to show at least very promising results to that end. So briefly, the project description was a contract under the federal Beacon grant on the Big Island, and our task was to partner with private practicing PCPs on the island to improve the health status of their most medically complex patients. We had clinical aims, technology aims, as well as payment aims. And who is a complex patient? Someone who has multiple chronic conditions, and primarily frequent hospitalizations, readmissions, ER visits. Generally, they're within the top 1% to 5% of health plan cost. And they were challenging and time-intensive for the PCP and their offices. The enrollment process, where the health plans provided us with lists of their high-cost patients, which then the PCPs took a look at and added that kind of intangible piece about the patient. And then the PCP was the one that did the inviting into the program, not the care coordinator. And as a result, we had a very high enrollment rate, 84 and 82%, as opposed to more typically 50%. The PCP participation was essential, and on the Big Island, we had very actively participating PCPs. We did use a system, which is our own system called iHealth Home, that helped them to do the telehealth monitoring, but also engage them in really understanding their health conditions and improve their health literacy. So did we improve health? Yes. Of the population, and the time period of intervention was between 6 and 9 months only. The total study was 12 months, including startup and data collection. So hemoglobin A1Cs for the population was 36% better. Total cholesterol was 19% better. So this was from the baseline 12 months prior to beginning of care coordination to between 6 and 9 months of intervention after. LDLs were 10% better. HDLs were 13% better. Triglycerides were 37% better. Systolic BP was 11% better. Diastolic 13% better. Weight 9% better. Inpatient admits for the total population were down 29%. Although on the Hilo side, we were able to achieve a 40% improvement. ER visits was a 25% reduction, and again, on the Hilo side, it was a 44% reduction in ER visits in a very short period of time. So did we improve costs? I mean, sort of anecdotally, if you're reducing inpatient admits and ER visits, you would think it would be reflected in the cost. And only one payer participated in helping us look at cost data. That payer had 42 of 72 of the enrollees. And the conclusion, even though it was a very small sample size and it was a very short period of time, but certainly the direction was in the right direction. It was showing a 32% reduction in per member per month cost for this payer. And it's kind of startling when you look at what the pre-intervention cost was versus the post-intervention cost. This population was costing $2,741 per month prior to the study, and then $1,800. So very sick, high utilizing. I guess in the state plan, these are the super utilizers. Patient activation was a really important piece for us because the one thing we have to do is improve the ability of the patient to take care of themselves. If all we end up doing is creating a new dependency, we haven't done our jobs. We have to have the patient take control of their plan. So we used a tool called the Patient Activation Tool, which was developed by the University of Oregon, that measures 4 levels of activation. And basically a level 1 person says, my doctor's responsible for my health, versus a level 4 person says, I'm responsible for my health and everything I do makes a difference in my health. So we were able to improve not only their scores, 33% better, but also their level, 54%. Now we also found, and we knew this intuitively, but we had to study it. We found that what is the proportion of the health issues versus the family and social issues? And we found it was split right down the middle, 50%. And most of our nurses who participated felt that the social issues were more important. Getting the patient activated, addressing their quality of life, helping their caregivers, and getting them socialized was almost more important than things like access to care, med compliance, functional status, insurance issues, and whatnot. Okay, the physician's perspective, I'll go really fast. The physicians, 91% agreed the program helped them, as same did the patient. 87 to 98% of the patients felt that they benefited from the program. And this was a particularly relevant comment where she says that healthcare is like a jigsaw puzzle, and her navigator helped her fit the pieces together. So lesson learned. Active PCP involvement is absolutely critical. We have to build trust by going into the home environment. We have to simplify our conversation, help our clients make cause and effect connections. Using technology is one way to do that. breaking their barriers, making early quick wins for them, understanding the caregiver support system was critical. Helping the wife, helping the daughter, helping the partner was just as important as helping the client. Having those conversations with those that had life-limiting diagnoses and getting that conversation started as early as possible, as Ken knows. Health information exchange is critical. If we're going to have this be cost-effective, our nurses were chasing paper everywhere just to try to get a picture of the patient's situation, and we've got to make that easier. Data transparency from the health plans is critical. The health plans have a lot of information about what's going on with that individual, and if we just could get a better picture of it sooner in the process and have that transparency, it makes it a lot faster to engage. Selecting the right patient. We do want to select a patient that is willing to change, and community collaboration was a must. Literally surrounding the patient, that everyone in the study, the hospital knew who they were, the federally qualified health centers knew who they were, the labs, the pharmacies all knew who they were, and were able to participate in the plan of care. So our biggest achievement, we believe, is for the participants in the study, we really did improve the health status of our neighbors. Thank you.
Thank you, Duane, and all of our speakers. We'd like to open this up to questions from the audience, and if you have any questions, could you please come up to the microphone? And maybe I'll kick things off. I wanted to ask, as I mentioned, we represent the gamut of healthcare providers. So our hospitals, are focused, one of the things the Affordable Care Act has really emphasized and is making them focus on are the penalties related to readmissions. Right, so I was hoping that you folks could walk us through, right, with an individual who has been hospitalized, has transitioned to a nursing facility, and then the family at that point, how can they access information in the community about different options? What's happening and what would be ideal from that transition from a nursing facility, maybe to home health care, and then to hospice and the care coordination that goes along with it? So Nancy, maybe if you wanted to start?
Oh, well, okay. Certainly, a good source of information now becomes the Aging and Disability Resource Center, either by telephone, which is 643-ADRC from any place within the state of Hawaii. If you dial 643-ADRC, which is 2723 for the last 4 digits, then the call is answered by a person on the ADRC staff who resides in the county from which that phone call is originating, since we do organize services that folks can access for their home support to live at home and to help with planning what their options might be. Those folks are based within the counties, and so we can use that telephone number to be a point of access. Also, hawaiiadrc.org is the online way to do that, and there is an online brief self-referral form, or neighbor can refer someone else form, or daughter-in-law can refer mother-in-law form, whichever way you want to use it, that would give a way for a person to make an online request to be contacted by a staff member of the ADRC to follow up with concerns. So that's one way.
Okay. And what would be an ideal transition then, moving out into a home setting?
Well, I think one of the things we found with care coordination is there are a lot of resources in our community, fabulous resources, free resources, social services. There's a lot of resources. Problem is, a lot of times the client doesn't know about them, and they don't know they need them. So really going out to the home, visiting the home situation, and helping them understand what do they need, why do they need it, and then making that connection happen to the resources has been a very valuable process.
Great.
I like the phone numbers. It felt like the Hawaii pledge drive. So call now and send your money in. Rachel, some of the other things that are available is we see that the hospital systems are reaching out to the network of providers in their community, Windward side, Leeward side, bringing the home care hospice providers together, the private duty providers together, saying we share in this problem together and setting up those systems. Frankly, I think Dwayne's right. There is a tremendous amount of resources available, but not everybody knows that. And just coming together on a regular basis and saying, these are the services that we have, kind of having that mutual self-enlightenment going on, really begins to break down some barriers as well.
And then what would be an appropriate transition from, let's say, home health care to hospice?
Soon. The transition to home care to hospice is just two agencies talking together and then going out and having a conversation with that patient and family about what their goals for care are. It's hard for the non-hospice people to understand what might be eligibility criteria for hospice. A friend of mine on the mainland said one time, they started this campaign that said, if your loved one is falling a couple times a month, if your loved one is needing help in 2 or more activities of daily living, maybe it's time to think about hospice care, just to start that conversation. All the hospice care providers were happy to go out and have that conversation, even just a professional to professional on the phone.
Great, thank you.
Yeah.
Brad.
This is mostly a question for Duane. I work at a federally qualified health center, and we're looking at care coordination, of course, with medical homes. For your services, I had 2 questions. One, what is the client to staff ratio that you're looking for? And 2, what is the type of training that you provide for your new staff to get them to be able to go into a home and do this complex assessment?
Very good question. Start with the training. We actually approach it as a team. So rather than it just being one individual as the point of contact, we have a team nurse, a health coach, and what we call our navigation assistant. And we really have each one working at their appropriate level. Generally, at the beginning of this case, you need the registered nurse because it's highly clinical. There's a lot of intervention with the primary care physician. The ability to just talk shortcut is really, really important. The health coach normally comes in a little bit later in the process, could also be a social worker, but we find a health coach works a little bit better in helping them to motivate them as opposed to do it for them and really get them to address the issues within their own life that are causing the health issues. Most of our coaches go through some sort of health coaching certification program. We like to try to have our registered nurses do that as well. And then we have a navigation assistant that's more of a really good clerical assistant that can just find all the resources and make all the appointments and have a lot of conversations with the client and their family member at home. So it really takes a team approach. And that's also important because, as with any position, there's turnover. The families develop a really close relationship with the care coordinators. So you don't want to have only one person. You really want that team. So there's multiple points of contact for the family. So in terms of the ratio, typically one RN, I think nationally it's pretty about 35 to 40 on the RN side. Because we have a team, we try to leverage that so that the whole team carries 100. And together with the technology, it makes that possible. The technology improves the productivity about 20%.
Great, thank you. One more question, yes.
Yeah, I'm wondering if you could comment on what we're doing at a statewide or broader systems level. I've been reading with interest what's been happening in Oregon, which I believe is a state that's furthest ahead in the Medicaid population, and very broadly using intensive case management, care coordination principles to dramatically lower the cost of their Medicaid population. And from what I understand, they've had really good results. Is there any dialogue like that happening here in Hawaii?
Yeah, I believe that is actually the model, the model that the state would like to adopt. And I happen to have been in Oregon and talked with the medical director there. And for those of you that don't know, what the state of Oregon did was split up the state into 14 care coordination regions, and then awarded contracts to only one care coordination organization per region. Okay, and I can tell you that personally, I think that makes a lot of sense. When we were in the Beacon Project, working with the doctors, building as much of a trust relationship with the doctors and their office staff and the workflow and the community was just as important. And what we heard time and time and time again from our physicians is, I don't want to work with 12 care coordinators. Every health plan has their own care coordinator. Every health plan has their different way of doing things. I got to do it one way for you and a different way for HMSA, a different way for United Healthcare, and the providers are just exhausted. It's creating more paperwork and bureaucracy for them to work with care coordinators because there's multiple approaches. And the other thing we found on the Big Island is you have to take a systems approach. You really do, to whatever the regional ecosystem is. And for example, Hilo is very different than Kona, is very different than North Hawaii. And each of those are their own medical ecosystem. And you find the same coordination problems occurring within the respective regions. If you're taking, when you look at it from the patient's perspective, you say, okay, this one can't get to behavioral health, that one can't get to behavioral health, that one can't get to behavioral health. This one is not able to get authorization because they don't have a PCP. You find the same problems occurring within a region when you take that care coordinator's point of view. And I think if we can begin to identify what are the systemic issues within the region and then address them as a community, that would be great. But you've got to have that care coordination overlay on the top. That's my personal opinion.
I just wanted to also share that, for those of you who have been involved with the SIM grant process, that Community Care Networks has been part of the discussion, and hopefully we will be able to move forward in that vein. Violetta, we have to wrap up. Okay. So what I'm going to share is that folks are welcome to come up to the table. When we put together this panel and we brainstormed in the beginning, we talked about providing the broad context of what's going on, policy, and getting to a more granular level. And when we compared what everybody's doing, we said, the future is now. So you have here some experts here who can share about the innovations that are going on in the respective fields, but that it really is a continuum of care. So with that, I'd like to thank everybody for coming. Thank our speakers.